Patients here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in emergency
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Imagine you have a patient, right? And they're suffering from this severe, just debilitating itching caused by liver disease. Or perhaps a breast cancer survivor who is struggling with these intense, really disruptive hot flashes, and they just cannot take hormone therapy.
Right.
What if I told you that the solution to both of those vastly different clinical problems is, well, it's actually one of the most famous psychiatric antidepressants in the world?
Yeah, it sounds completely counterintuitive when you look at it on the surface. Like, you would normally never associate a mood medication with, liver-induced itching or temperature regulation.
No, not at all.
But, I mean, that is the beauty of looking past the basic labels of pharmacology. You have to understand the actual machinery of the drug.
And that is exactly what we are doing today. Welcome to the Deep Dive. Whether you are prepping to conquer nursing school, or maybe getting ready for a tough clinical rotation, or, staring down the barrel of the NCLEX, we are here for you.
Absolutely.
Because usually when you look at a pharmacology textbook or a drug monograph, it just feels like this endless, overwhelming list of side effects and enzymes and warnings.
Oh, yeah, it all just blurs together into this giant soup of medical jargon.
Exactly. And you feel like you have to memorize every single sentence just to be a safe practitioner.
Which is, frankly, an impossible standard. So today, our mission is to act as your elite clinical pharmacist and expert nursing instructor combined. We're applying the Pareto principle.
Right, the idea that 20% of the information will give you 80% of your clinical understanding.
Exactly. We are taking a single, highly tested, incredibly common medication and extracting only what truly matters for your clinical practice and your exams.
We're going to transform dense pharmacological data into actionable, memorable insights. Because here's the secret to mastering meds. You don't memorize them by rote. You learn their personality.
I love that approach.
Yeah, you learn their daily habits, their worst enemies, and their weird little quirks. And today's personality profile. Sertraline, better known by its brand names, Zoloft or Zerkapli.
Right, so to set the baseline here, sertraline is a selective serotonin reuptake inhibitor, or SSRI. It sits firmly in the antidepressant drug class, and it is not a controlled substance.
Okay, so let's get right into the engine room here.
Yeah.
The mechanism of action. I always like to explain this first step with an analogy.
Go for it.
Okay, think of sertraline as a really strict bouncer at a nightclub. The club itself is the synaptic cleft, that tiny space between the neurons in your brain.
Okay, I'm with you.
So serotonin is out on the dance floor having a great time, transmitting those positive, mood-boosting signals. But eventually, serotonin tries to leave the dance floor through the reuptake doors, right?
Yes.
To go back into the original neuron.
Right, to be recycled, essentially.
Exactly. But sertraline stands at those doors, blocks them, and says, nope, you're staying on the dance floor.
That bouncer analogy is great. It perfectly visualizes the immediate localized effect. Sertraline selectively inhibits that reuptake pump at the neuronal membrane. But if we dig just a bit deeper into the biological magic, we uncover the long-term effect. Because just trapping serotonin in the synapse isn't the whole story.
Which makes sense, because if that were the case, your patient would take their first pill on Monday morning and feel like completely better by Monday afternoon.
Right. But they don't.
No, they don't. We always counsel patients that it takes weeks to see a change. So what is actually happening during that lag time?
Well, it really comes down to how the brain adapts to its environment. Initially, the SSRI increases the availability of serotonin at the receiving end of the neuron.
Okay.
But over time, because there is constantly so much serotonin hanging around, the brain's serotonin autoreceptors actually downregulate. They desensitize.
Oh, wow. So to stick with the club analogy, the brain essentially gets used to the loud music and just stops trying to turn the volume down.
That is exactly it.
So it physically remodels the neurological landscape.
Precisely. This adaptation allows the neuron to eventually increase serotonin release at the sending end, the axon terminal synapses.
Okay, so that delayed receptor change, that physical structural adaptation, that's the true mechanism of action.
Yes. That is exactly why it takes weeks to see the therapeutic effect.
That is fascinating. It's not just a chemical blockade, it's forced neurological remodeling.
Yeah.
And, understanding this high level of selectivity also explains why it's so much cleaner than older medications. Like, if I remember correctly, older antidepressants, like the tricyclic antidepressants or TCAs, they were notorious for knocking patients out and drying them up like a raisin.
Oh, absolutely. And that happens because TCAs are messy. They bind heavily to histaminergic receptors.
Which causes the severe sedation.
Right. And they bind to muscarinic receptors.
Which causes those severe anticholinergic side effects.
Yeah.
Like extreme dry mouth and urinary retention.
Exactly. But sertraline, true to the selective part of SSRI, it dramatically decreases binding to those other receptors.
So the bouncer only cares about the serotonin doors.
Exactly, which means fewer of those miserable sedative and anticholinergic side effects for the patient.
Okay, so clinically, we know it enhances the actions of serotonin. But on the floor, what are the expected actions? Like, how do we know this medication is actually doing its job?
Well, we are looking for a tangible improvement in depressive symptoms, a significant reduction in anxiety levels, or a decrease in compulsive behaviors.
And again, you are tracking this progress after several weeks of continuous use.
Right, exactly. You have to give it time.
Because it physically changes how the brain handles serotonin. It's not just for depression, which explains why we see it used for such a surprisingly wide range of conditions.
Oh, yeah, the list is long.
For the priority indications, the ones you will absolutely see in nursing school and practice, we have major depression, panic disorder, posttraumatic stress disorder, or PTSD, social anxiety disorder, and premenstrual dysphoric disorder, or PMDD, in adults.
And we really must highlight a major pediatric priority here. Sertraline is specifically approved for obsessive-compulsive disorder, or OCD, in children as young as 6 years old.
Wow, 6 years old.
Yeah.
Now, that brings me back to the hook we started the show with. I was looking through the source material, and I saw these off-label uses that initially made zero sense to me.
The itching and the hot flashes.
Right, giving a powerful psychiatric drug to someone with cholestatic liver disease.
Oh.
Or a breast cancer survivor experiencing hot flashes. Like, why?
It really highlights just how systemic serotonin really is. Let's look at cholestatic liver disease. It can cause severe debilitating pruritus, which is uncontrollable itching.
Okay.
Well, it turns out serotonin is heavily involved in the specific neural pathways that transmit the sensation of itch to the brain.
Really?
Yeah. So by altering those serotonin levels with sertraline, patients often report a massive improvement in that severe itching.
Okay, that makes perfect sense when you frame it around the neural pathways. What about the hot flashes, though?
For hot flashes, whether due to menopause or, in women treated for breast cancer who are contraindicated for hormone replacement therapy, SSRIs provide a non-hormonal alternative.
Because they can't take estrogen.
Exactly. The hypothalamus acts as the body's thermostat, and it relies heavily on serotonin to regulate temperature. So sertraline basically helps stabilize that thermostat.
It's incredible how one neurotransmitter controls so much. I mean, the source material also mentions it's used off-label for binge eating disorder.
Right, presumably because serotonin helps regulate impulse control and satiety.
And also for premature ejaculation. Because one of the known side effects of SSRIs is delayed ejaculation or increasing ejaculatory latency.
Exactly. We are taking a known side effect and utilizing it as a therapeutic off-label treatment.
That's brilliant. But here's where it gets really interesting for anyone administering this drug. For a single medication to affect everything from your mood to liver-induced itching to your body temperature, it has to have a highly specific journey through the body.
The pharmacokinetics.
Right. And when we look at that journey, the first thing that jumps out is the protein-binding twist. The data says sertraline is 98% protein bound in the blood.
It is highly bound. Very highly bound.
Now, as a nursing student, the moment I hear a drug is 98% protein bound, all my alarm bells go off.
As they should.
I immediately think of the blood thinner warfarin, which is also highly protein bound to albumin. I was always taught that if you put two highly protein bound drugs in the blood at the same time, they fight for the seats on the albumin protein.
Right, the competition.
Yeah, one gets bumped off, floats freely in the blood, becomes active, and suddenly the patient bleeds out. Are you telling me we have to constantly monitor for a massive bleeding risk when these two are mixed?
That is the exact critical thinking we want to apply, honestly. But this specific scenario raises an incredibly important clinical pearl.
Okay, lay it on me.
No, they do not fight for space.
Wait, really?
Really. Sertraline is unique. It doesn't bind to albumin the way warfarin does. It has a presumed binding site on a completely different protein called alpha-1 acid glycoprotein.
Ah, so because they bind to completely different proteins, they aren't competing for the same seats on the bus.
Precisely. Sertraline takes the alpha-1 acid glycoprotein bus, and warfarin takes the albumin bus.
Okay.
They bypass each other entirely, which is a massive relief for anyone managing complex polypharmacy patients.
That is such a vital nuance for exams. Wow. Okay, let's look at the timeline of this journey. The half-life is about 26 hours, and it reaches a steady state concentration in the blood in about a week.
Right.
It's partially excreted in the feces. About 12 to 14% goes out unchanged that way. But the real organ we need to worry about is the liver.
Oh, the liver is the absolute star of the show here. Sertraline undergoes extensive first-pass metabolism in the liver.
Meaning?
This means the liver processes a huge portion of the drug before it ever reaches systemic circulation. Because of this heavy reliance on hepatic processing, if the liver isn't working properly, the drug can quickly build up to toxic levels.
Okay, so practically speaking, if I have a patient with mild hepatic impairment, what happens to the order?
The prescriber must reduce the standard dose by 50%.
Half the dose.
Okay.
And if the patient has moderate to severe hepatic impairment?
You do not use it at all. It is strictly contraindicated.
Since it's so heavily metabolized by the liver, I'm assuming the kidneys get a free pass here.
They do, actually. Renal impairment requires no dose adjustment.
Perfect. Now let's talk about route and administration, because there are some massive NCLEX gold mines hidden in here.
Oh, absolutely.
Sertraline is oral only. You can give it in the morning or evening. You have your standard rules like do not chew or crush the capsules. But the liquid formulation, the rules for the oral solution are incredibly rigid.
They are notoriously strict, and you really must know them to safely administer it. First, the oral solution must be diluted before you give it. You cannot just squirt the concentrated liquid into the patient's mouth.
Right. And I noticed you can't just mix it into a cup of coffee or milk either.
No, absolutely not. Due to the chemical stability of the drug, it can only be mixed with exactly 4 ounces. That's 120 mLs of water, ginger ale, lemon lime soda, lemonade, or orange juice.
Wait, that's it?
That is the exclusive exhaustive list.
Only those 5 liquids. And after you mix it, the source notes a slight haze might appear in the glass. I imagine a lot of nurses or patients might see that cloudy haze and think, the medication has gone bad.
It is a really common misconception, but that haze is completely normal. You just proceed with administration.
Okay.
And crucially, you must have the patient consume the dose immediately after mixing. You cannot prepare this in the med room at 6 a.m. for an 8 a.m. med pass. It will degrade.
There is one more sneaky administration quirk here that could literally save a life. The dropper that comes packaged with the liquid formulation contains dry, natural rubber.
Yes.
That is a massive red flag for any patient with a latex allergy. It's a tiny detail that could trigger a rapid anaphylactic reaction if missed during the admission assessment.
It's so easily missed, too. And anticipating those systemic reactions perfectly transitions us into what happens when sertraline bumps into other substances in the body, the drug interactions.
Right. We already established it relies on the liver, specifically the CYP450 enzyme system.
Yes, the CYP450 system.
The sources specify that sertraline inhibits the liver enzyme, CYP2D6. Now, I used to think of enzymes as garbage disposals, just destroying things.
No.
But they're really more like a factory assembly line, processing and packaging chemicals.
That factory assembly line is a much better way to visualize it. If sertraline inhibits or slows down the CYP2D6 assembly line, any other drug that requires that specific line to be processed is going to get backed up in the warehouse.
Right, it just piles up in the bloodstream.
Yes. The clinical impact here is that nurses and prescribers must recognize that other drugs metabolized by CYP2D6, things like certain antiarrhythmics or antipsychotics, they might need their dosages reduced.
Because sertraline is hogging the assembly line.
Exactly, to avoid toxicity.
That makes perfect sense. Now let's talk about what happens when the drug causes unintended effects. Let's break down side effects versus adverse effects, and more importantly, why they happen, because there are a lot.
There really are.
So the mild, common ones you expect: nausea, diarrhea, insomnia, xerostomia, which is dry mouth dizziness, and fatigue.
Right, standard SSRI fare. Then you have the moderate effects. These are the ones that most frequently cause patients to become non-compliant, specifically sexual dysfunction.
Which includes delayed ejaculation, impotence, and decreased libido.
Exactly.
Why does an antidepressant cause such profound sexual dysfunction, though?
Because serotonin has a broad inhibitory effect on sexual arousal pathways in the spinal cord. While it boosts mood in the brain, that surplus of serotonin actively dampens the physiological arousal response further down the central nervous system.
So it's a direct result of the mechanism of action, not just like a random allergy.
Right.
That logic also applies to the serious, life-threatening adverse effects we have to monitor for. For instance, the sources list GI bleeding as a severe risk. Why would a brain medication cause your stomach to bleed?
This is a brilliant connection to make. Platelets in your blood are responsible for clotting, right? But platelets don't manufacture their own serotonin. They have to extract it from the bloodstream.
Oh, I see where this is going.
Yeah. When sertraline blocks serotonin reuptake, it also blocks the platelets from grabbing the serotonin they need to aggregate effectively.
Wow.
Without that serotonin, platelet function is impaired, leading to a significantly higher risk of gastrointestinal bleeding.
Wow. So an SSRI literally makes your platelets worse at their job.
Yeah.
That is wild. What about serotonin syndrome? That's the classic nightmare scenario we hear about.
Yeah, serotonin syndrome occurs when the drug causes a toxic, potentially fatal accumulation of serotonin in the central nervous system.
And what does that look like?
It leads to extreme autonomic hyperactivity. Think severe tachycardia, hyperthermia, shivering, sweating, and hyperreflexia. It is a medical emergency.
The sources also list severe skin reactions like Stevens-Johnson syndrome or DRESS.
Yes. DRESS stands for drug reaction with eosinophilia and systemic symptoms. It's a severe systemic immune reaction where the body essentially attacks its own organs, accompanied by a widespread rash and fever. Like Stevens-Johnson syndrome, it requires immediate discontinuation of the drug and emergency intervention.
We also need to watch for QT prolongation, which is an electrical issue in the heart that can trigger dangerous arrhythmias. And finally, hyponatremia, specifically linked to SIADH.
Right, syndrome of inappropriate antidiuretic hormone secretion.
How does that connect?
Building on the mechanism again, sertraline can prompt the posterior pituitary gland to release too much antidiuretic hormone.
Oh.
So the kidneys respond by holding on to too much free water, which dilutes the sodium levels in the blood. If that sodium drops too low, the patient will experience confusion, lethargy, and eventually seizures or a coma.
Knowing these life-threatening risks, it really shifts our focus to the front lines. Who should absolutely not take this, and what must the nurse actively do and teach?
Exactly.
We established that we avoid use in moderate to severe hepatic impairment. But there's a major precaution for pediatric patients too, right?
Yes, you must use extreme caution in pediatric patients because of a documented potential for growth inhibition.
Why does that happen?
The surplus of serotonin can actually suppress the secretion of growth hormone, leading to decreased weight gain and stunted growth observed in children receiving long-term SSRI therapy.
Which means, as a nurse, one of your independent priority actions for pediatric patients is strictly monitoring their height and weight periodically on that growth chart.
Exactly. And monitoring hepatic function via liver enzyme panels to ensure that first-pass metabolism is still functioning safely.
But the most critical safety parameter for this drug, the one that will undoubtedly be on the exam, is the black box warning.
A black box warning is the absolute strictest warning put on the labeling of prescription drugs by the FDA. For sertraline, the warning is for an increased risk of suicidal thoughts and behaviors in children and young adults, specifically those 24 years of age and younger.
I want to paint a clinical picture here because the nuance in the source data is really vital.
Go ahead.
Let's say you have a 19-year-old patient who is profoundly depressed. They have severe psychomotor retardation, meaning they barely have the energy to get out of bed. They start taking sertraline. Did the medication actually cause more completed suicides in the pediatric trials?
This is a crucial distinction. No suicides actually occurred in any of the pediatric trials.
Okay.
However, the ideation, the thoughts and behaviors, were highest. And they peak at two very specific times, right at treatment initiation or immediately following a dosage change.
And the rationale for this is terrifying, but makes clinical sense. 2 weeks in, the medication might give that severely depressed patient the initial physical energy and motivation to act on their dark thoughts, long before the cognitive mood-lifting effects and receptor remodeling have fully kicked in.
That is exactly the danger zone. The physical energy returns before the emotional despair lifts.
Which dictates our nursing interventions and patient education. If you are discharging a young adult on sertraline, your #1 priority is teaching the caregivers and the patient to actively monitor for and immediately report any sudden changes in behavior, worsening depression, or suicidal ideation.
You also must teach those strict mixing rules for the oral solution. Remind them. Only water, ginger ale, lemon lime soda, lemonade, or orange juice.
Exactly 4 ounces.
Consume immediately. Do not prep it in advance.
And finally, expectation management. If you don't teach them about the delayed mechanism of action, they might take it for 3 days, experience some mild nausea and dry mouth, realize their mood hasn't changed at all, and just throw the bottle away.
Patient compliance relies entirely on them understanding that the brain takes weeks to physically remodel its receptors. They have to trust the timeline.
All right, we've covered the deep pharmacological data, the strange off-label uses, the rigid liquid rules, and the black box warnings. If you are walking into an exam or a clinical shift tomorrow, let's distill this into your rapid-fire priority summary.
Sounds good. We will start with the must-know. You must know the black box warning. There is an increased risk of suicidal ideation in patients 24 years of age and younger. You must monitor them with extreme vigilance, particularly during the first few weeks of treatment and any time the dose is adjusted.
Got it. Here is your nice to know. Sertraline is 98% protein bound, but it uniquely takes the alpha-1 glycoprotein bus, not the albumin bus. This is exactly why this highly protein-bound drug doesn't dangerously fight with warfarin.
The test trap. The oral liquid formulation. Test writers love to hide this in a multiple choice question. It must be mixed only with the specific 5 liquids we discussed. A slight haze after mixing is completely normal, and the dropper contains dry natural rubber, making it a major latex allergy risk.
The clinical red flag. Monitor your patients closely for severe adverse effects like serotonin syndrome, SIADH causing severe hyponatremia, and GI bleeding. If a patient on sertraline suddenly becomes confused, agitated, or starts showing unexplained bruising, you notify the provider immediately.
And finally, your 1-sentence memory hook to tie the entire personality profile together. Sertraline keeps serotonin at the synapse, but watch the liver, the liquid, and the little ones.
Watch the liver, the liquid, and the little ones. I love that. It perfectly covers the hepatic impairment risks, the crazy liquid mixing roles, and the pediatric dangers of growth inhibition and suicidal ideation. That is the Pareto principle, beautifully applied.
But before we sign off, I want to leave you with the final clinical puzzle to mull over as you head to your shift.
Ooh, wow.
We discussed that sertraline works not just by blocking reuptake, but by forcing serotonin autoreceptors to downregulate and physically remodel over a period of weeks.
Right, it forces the brain to structurally adapt to this new high serotonin environment.
So if that intense neurological remodeling is required to achieve the therapeutic effect, how might that same structural change explain why tapering off SSRIs requires such slow, careful clinical management?
Oh,
Think about it. If you just abruptly stop the medication, what happens to a brain that has completely remodeled itself to rely on that bouncer at the door?
that is a fantastic question to take onto the clinical floor. Thank you so much for joining us on this deep dive. Take this masterclass knowledge, look past the basic flashcards to understand the true personality of the medication, and go conquer your clinical practice. You've got this.